section is going to feature Dr. Christina Vaughn and Crispin Sargent. First, we'll speak with Dr. Christina Vaughn, Division Chief of Neuropalliative Care and Professor of Neurology and Medicine at the University of Colorado School of Medicine. Dr. Vaughn specializes in movement disorders and hospice and palliative medicine. So please welcome Dr. Vaughn.
Hi, good morning. Thanks so much for having me. I'm going to see actually if I can use this mic here. Is that okay? Okay. Okay. Does that work? Yeah, I think how about now? That's okay. I'll stick with the regular. Okay. I changed my mind. I'll stick with this one just to make it easier. So I was asked to speak about 3 topics: palliative care, hospice, and medical aid in dying. My colleague who will be joining me in this session, Crispin Sargent, will speak more about medical aid in dying, so I'll spend less time on that topic. But these topics tend to have more emotion associated with them and are much more clinical than the exciting research-related topics we've been hearing so far. So I'll go ahead and get started. So I wouldn't mind if you would shout out, if you feel comfortable, some words that come to mind when you think of the word or the words palliative care. I'm just curious, what comes to mind? There's really no wrong answer. Providing comfort. Sorry? Support. Anything else? Engaging where we're starting with today. I think this audience is probably a lot more knowledgeable than others in other parts of the country even. I think it depends on what region we're in. Well, palliative care came out of cancer care, actually, originally, but it's evolved to become a lot more appropriate for other conditions that are progressive and serious, such as HD and others. And very briefly, palliative care is medical care focused on improving quality of life for people living with any sort of serious illness at any stage, from the time of diagnosis or any time after that. And if I could really distill it down, it's about living as well as possible, as long as possible in the face of a serious condition. And I really want to emphasize the word living, because all too often when I ask groups, what words come to mind with palliative care, sometimes people think about things other than living. And in fact, it's about living as well as possible. And a typical palliative care team, or at least what we have here, is certainly with the patient and family at the center and several different disciplines working together. The palliative care clinician, which could be a physician or a nurse practitioner or a PA, a nurse or nurses, social work, chaplain or spiritual care, psychologist, and we're lucky now we have a pharmacist in our clinic. And so this makes up the key components of a clinical or in-clinic palliative care group, ideally. And I'll introduce this topic to you that's a palliative one. It's called total pain. Came out of the palliative care world, and it's the idea that if we want to address a symptom, whether it's pain or something else that's significant, we really can't do as good a job if we're just focused on the physical. We do a much better job and can be a lot more effective if we recognize that physical symptoms have other components too. If you follow this wheel around, there's the emotional side, potentially the spiritual or even existential side, the practical side of living with symptoms or a medical condition or a neurologic condition, the social side. And so that's why palliative care teams have multiple different disciplines as part of the team, because we recognize that if we focused with blinders on just on the physical, or maybe the physical and just the emotional, we'd be missing out on the other impact or the other domains of impact that people have when they're living with such conditions like HD. There are many benefits of having palliative care involved in a chronic condition. Certainly helping with effective symptom relief has shown to improve quality of life, again, by addressing these multiple domains as much as we can: physical, emotional, spiritual, psychosocial, as well as focusing on caregivers. The intent is not just to put blinders on and focus on the patient, but to recognize that whoever is with them, close to them, comes to the visit with them, that's part of who we're focusing on. We try to ask that person or those folks how they're doing. Are there opportunities that we have to help them too? Certainly, they're not our patient technically. We're not writing notes on the caregiver and prescribing things, but we are trying to check in with them and see if we can connect them with resources as well, or even to normalize things. Sometimes caregivers or families might be reluctant to bring up something, and if we can get them to do that, sometimes we can normalize or put things into context that they may not have been eager to talk about before. And then because we focus on advanced directives and planning for the future, sometimes we can minimize unnecessary hospitalizations, where the cycle that sometimes happens when people have very advanced disease and might be in and out of the hospital with infections or other things, we might be able to avoid or mitigate that, or emergency visits, or even aggressive treatments at the end of life if somebody doesn't want that, or if it doesn't make sense with their values. And so these are just some of the ways that we strive and actually do help people, patients and families living with a chronic condition. How do we do that? Well, I would say our greatest tool, if you could call it that, is the goals of care conversation, the discussion. This is where we try to understand what matters most to people, what their values and priorities are. All too often in medical care, we can get on automatic pilot, right? Where you come into a medical visit, whatever the specialty is, and we jump straight to the medical and say, okay, how's this symptom? How's the chorea? How's the walking? Let's focus on that. And certainly that's important, but we'd be remiss if we didn't check in about actually what the patient is hoping for and what they're hoping to do, goals that they have. And so goals of care discussions are really how we start, especially our first visit when we're first meeting a patient in clinic. We'll ask questions like, what was life like before you got sick? We really want to understand the story. And while it might feel strange to be in a medical setting with medical people asking you about your life story, what we're trying to do is understand better how things were truly before the disease kicked in and became symptomatic, and understand what's important to people. We'll ask questions about the future. Are there situations that you're worried about or want to avoid? Alternatively, what are you hoping for? Hope and worry are two sides of the same coin, but they're both future-oriented, and we really lean on those questions a lot in our visits to try and understand where people are at, what they're expecting or hoping for. So the goals of care discussion is really the foundation for additional discussions regarding planning for the future, which includes medical decision-making. We really enjoy and like to help patients and families, support them around medical decisions. For example, if somebody with mid to late stage Huntington's disease is being told by their primary care doctor, it's time for your colonoscopy. Maybe that makes sense, maybe it doesn't. So for example, that could be a discussion we'd have about, let's talk about that. Does it make sense to get this colonoscopy or this elective procedure? Maybe or maybe not. So talking through that and not just automatically moving forward with whatever other medical specialties are recommending is part of what we like to help with. And advanced care planning as well. Planning in advance for the what ifs of the future. Getting the patient's voice, capturing their preferences as soon as we can, recognizing that they can change certainly over time, but having those conversations earlier just to set us up for success, so that if things happen that go wrong or medical emergencies happen, we at least can lean on prior discussions about what would be acceptable for that person or not as far as medical interventions. So we talk a lot about what if medical scenarios. What if you won't be able to swallow safely in the future? What are our options? Would you be open to the possibility of artificial nutrition through a tube? Some people say, yeah, I think that sounds good if it's going to extend my life, because life prolongation is what's most important to me. Other people say, you know what, I've seen people with feeding tubes. I definitely don't want that. But we don't know until we ask. And that's what this is about. Advanced care planning is about asking these questions, not focused only on these things, but certainly making sure these are part of our visits. And then documenting this, right? It's one thing to have the conversation. It's another thing to actually put it in writing, and we help with that. People don't realize a lot of times that you don't need an actual attorney to document your medical wishes, especially in Colorado. Medical providers can help you with that. You don't have to pay any money. You don't have to go through special hoops. We can document that with you. And where can you find palliative care? Actually, in 3 different types of settings. One is in the hospital. If you're hospitalized for whatever reason, palliative care teams usually exist in major hospitals. In fact, Dr. Forbes and I just shared a patient with advanced Huntington's who was hospitalized for pneumonia. And having palliative care involved is absolutely possible in a hospital setting. In the clinic, that's where I spend a lot of my time, in a non-emergent setting, having a clinic visit. And then third is community-based palliative care programs. Sometimes people aren't aware of these. They exist. They're usually affiliated with a hospice. It's a different arm. And this is a team that comes to the home and visits, or wherever the patient is, and visits with them every 4 to 6 weeks. It's not very often, but it is another set of eyes. And the palliative care team can come to the home or the facility if somebody's in one. So hopefully I have, I have limited time for this talk, but we'll have a Q&A in a few minutes. Hopefully I've shared with you the idea that palliative care is about living and being proactive and trying to raise up what's most important to people. And I'll remind you that the word palliative itself comes from palliare, which means to cloak, kind of like the idea of a mantle. And I love this visual because it's really meant to be like another layer or a cloak of support, just another dimension of support. And I mention that only because sometimes people say, hey, why don't you change the name to something else other than palliative? Palliative has a bad rap. And I say, no, I love this word. It makes sense. All right. So when should this occur? As I mentioned, it can happen anytime from the time of diagnosis or afterwards. It's never too early. There's not like a right time, right? Sometimes people say, even colleagues are like, well, we're not ready for that yet. Why not? I can also appreciate that it might be a burden to have yet another medical visit, so we do want to be sensitive to that. But there's no reason to wait for palliative care to have these conversations. Ideally, it's proactive and not reactive. Triggers to involve palliative care could include times when you have complex decisions that you want to discuss around surgery, transitions in care, a new medical diagnosis, some other new problem that's started, which can happen. Advanced care planning, if you want additional help with symptoms or another perspective to help with physical or other symptoms. And then if there's real need for support of the care partner or family. These are all possible reasons to trigger a palliative care referral. And how can you don't have to have a palliative care referral or see a palliative care team to actually start having a palliative approach in your regular neurology or primary care visits. Ways you could do that or empower you to have these conversations with your pre-existing medical team could be to ask questions like, I'd like to discuss my priorities and what's important to me, what's most important to me. If you initiate that or the family initiates that, that could start a palliative type conversation in a regular visit without having to go and see a new team. How about, can we talk about a Huntington's disease roadmap for the future? That could also initiate a conversation. Another one, future-oriented, might be, what do you expect things to be like for me in 5 years? Admittedly, we're not that great at prognosis, but we do our best, leaning on what we know about the disease course, what we know about you, the patient or the person in front of us. So we can try to lay out a roadmap or talk about what to expect in the coming years. And then another thing you could ask could be, can we discuss some what ifs of the future? This also could lead to a more palliative discussion. So that's my bit about palliative care. I'll spend a little less time on hospice care. Anything that comes to mind that you want to shout out when you think of the word hospice? What comes to mind first? Dying. Thank you for being honest. Yeah. Anything else? Yeah, you went straight to the heart of it. A lot of people think about dying. And I think hospice teams would actually appeal to you that while, yes, patients enrolled in hospice are towards the end of life, it's still about living because they're still with us and they're trying to optimize the days or weeks or months that they have left. So it truly is actually about both dying, but also living. And so it too is medical care focused on providing comfort for people who have a life expectancy of 6 months or less, when the primary goals really are symptom management and quality of life. That's really what it's intended to be. I think all too often in the US especially, we get hospice involved very late and it might be a reactive referral, like things are going downhill really fast for whatever the disease is. Let's get hospice in, and then the person passes away within days or short weeks. It's intended to be involved sooner, upstream from that, ideally, if possible, but it can be hard to predict when somebody is eligible for hospice or not. It's meant to be person-centered, and it comes to where the patient lives, right? If they're at home, hospice comes to them. If they're in a facility, hospice comes to them. And it's a team, also like our palliative team, this time led by a nurse with other domains or other specialists joining. It is a Medicare benefit. All Medicare and Medicare Advantage enrollees have a right to hospice care. Most major insurances also cover hospice care, so there's no out-of-pocket cost for the essence of what hospice is. It's not a 24/7 service in person. It's not 24/7 bedside care. It doesn't replace, if someone is in a nursing home, doesn't replace the nursing home care, and it does not hasten death. That's not the goal. It does, hospice teams all have a 24/7 phone number, so they become like the new 911 when people are enrolled in hospice. They also offer, all hospices have to offer bereavement support to the family 13 months for over a year after someone does die. So that's just a snapshot of some hospice highlights to share with you. To sum it up, hospice is both a service and a philosophy. Service meaning they come and they do things, they take vitals and check symptoms and adjust medications. But the philosophy piece means that this makes sense for patients who have a limited lifespan and who want to focus and prioritize comfort, who aren't necessarily interested in going back to the hospital or having medical tests or procedures. The goal is comfort. So when is the right time for hospice enrollment? It can be tricky. One thing that I rely on is the surprise question. I'll ask myself, would I be surprised if this patient in front of me were to die in the next 6 months, to die naturally? That's a different question than saying, do I predict it? So there are some instances where I see a patient, in fact, this happened yesterday in clinic, where I see a patient who I wouldn't be surprised if they died in 6 months, but maybe I wouldn't be surprised if they live beyond 6 months. In my opinion, these folks are eligible for hospice care. And I talk to the hospice teams and they often feel the same way. And this is a way to think about getting hospice involved sooner if the person's goals are truly thinking about comfort. And again, it brings medical care to the patient. And typically they're not going back to the hospital or having tests. When it comes to the hospice criteria for Huntington's disease and similar conditions, neurologic, things that we're looking at are if the person is transitioned to no longer independently walking, but really relying on a wheelchair or strictly in bed. If they're no longer able to carry out activities of daily living and requiring assistance for all or most of them, if there's a critical nutritional impairment, if there are life-threatening complications, breathing problems, and so on, and we're paying attention to activity level, their ability to provide their own self-care, again, nutrition, and sometimes people become really sleepy, not just with HD, but with other neurologic conditions towards the end of life, where they're spending most of their time sleeping on and off throughout the day or mostly in bed. These are some of the factors, this and weight loss, that we're thinking about when we're trying to gauge whether somebody is hospice appropriate. And lastly, just a couple of slides about medical aid in dying to segue into Crispin's discussion coming up next. MAID is how we call it. It has a lot of different names, but in Colorado, the most common term for this is medical aid in dying. What is it? It's a law that allows a clinician, a physician, or an advanced practice nurse, like a nurse practitioner now, can prescribe a lethal medication for a patient with a terminal diagnosis who has full mental capacity and the ability to self-administer if they make the request that they want to hasten their death. This has been legal in Colorado since 2016, the end of 2016, so we're approaching 9 years of having this law in our state. It's available in 12 jurisdictions in the US, and that map in the lighter blue shows you, including Hawaii, what other states have this currently as an option. The eligibility criteria include people who are 18 or older who are Colorado residents. They have to prove that with a driver's license or some other form. They need to be terminally ill with a prognosis, again, of 6 months or less. Once again, I lean on the surprise question when I'm trying to gauge this because it can be tricky to predict where somebody's at with respect to prognosis. And then these last two eligibility criteria are really critical, particularly when we're talking about neurologic conditions. The person has to have the mental wherewithal to be able to make such a decision. In other words, they have to have capacity. They have to also be able to self-administer the medication, which can be hard in some of our conditions that affect swallowing. That being said, they can self-administer rectally with a tube, so they don't necessarily have to rely on swallowing. But these are the in general, the key criteria that allows someone to be eligible to take advantage of this law. Briefly, there are 3 visits that are required, 2 with the prescribing provider and 1 with a consultant. The consultant's job is to verify that they agree that the person meets the criteria. And there's a written request where the patient has to sign putting in writing their desire to participate in this program, and that has to be witnessed by 2 individuals. So in my experience, I do get a fair number of people asking about medical aid in dying. Sometimes it's simply curiosity, but a lot of times it's a sign of some sort of distress that we've previously missed. And it's an opportunity and it necessitates exploration. When somebody brings this up in clinic, we've got to get comfortable and recognize we have a lot of exploring to do to sort out why they're making this request, where it's coming from, and how we can help. And we do see a lot of such requests for people living with neurologic conditions. It's not just cancer, it's not just end-stage liver disease or other things. Plenty of requests come in our neurology clinics for this. And so my take-home points, my final slide, are related to palliative care. It's about living as well as possible for as long as possible in the face of a serious illness. At any time, makes sense to involve palliative care, or at least to have a palliative kind of conversation in your typical neurology visit. The concept of total pain, I think, is a helpful concept to think about the various components of living with a chronic disease, not forgetting the spiritual, social, practical sides of living with these conditions like HD. And it's meant to support not just with symptoms, but with coping, future planning, and help with medical decision-making. Hospice, remember, is not just a service, it's also a philosophy. It's this focus on prioritizing comfort when somebody is approaching end of life. And medical aid in dying, again, has been legal in our state for almost 9 years now. And it allows people who are eligible and terminally ill to have a choice in how and when they die with medical assistance. So with that, I think we can save questions to the end because we're going to have a robust Q&A session, and Crispin's coming up to pick up where I left off.
Did it go on? Am I on? All right. You guys have had a long morning. I want to invite everybody, bring your shoulders up and drop them down. Bring your shoulders up, drop them down. Bring your shoulders up, drop them down. Twist around a little bit, look over your shoulders, say hello to the person behind you. Say, oh, so nice to see you today. And go around to the other side. So nice to see you today. Yeah, so one of my multiple trainings, I'll go through them. I'm certified as a grief yoga instructor. Where do we hold our grief in our body? How do we release it? And certified as a grief educator. So a lot of what it is that I do is around not only what's come, but where it is in our body and what do we do with it. So then I'm going to go backwards. I'm Crispin Sargent. I'm the education coordinator with End of Life Options Colorado. We're a small nonprofit. We've just been in existence for about 2.5 years. And we came about because after medical aid in dying was passed in Colorado, there was no follow-up education. So it's been here, but there wasn't community education to both the patients, to their care partners, and I very specifically use care partners because I was doing a session one time and a lady in the back of the room, when I said family, her shoulders came up, and not in a good way. And she said, I have no family. How dare you? And she stomped out of the room. So I recognize we're surrounded by our care partners. And of course, I lost my complete train of thought of what it is that I wanted to say. But the point on all of it is in this process of the education and what we're doing in options, and I'll just shorten it with options, education choices necessary because there hadn't been a component in the law that says, how are we going to let people know about it? The people, their care partners, the clinicians, and potential providers in the hospitals, in the facilities where they're living, and all of the people that they're working with. So that's our task. In my background, I had been a private fiduciary. Fiduciary meaning I was responsible for people's money. So I've spent the last 40 years as the medical power of attorney, the financial power of attorney, the trustee, the conservator, ultimately the personal representative, oftentimes working with people that did not have care partners, did not have family, or had dysfunctional family, and they needed an independent third party to serve in that role. So I come into this with my experience as the person sitting next to the person who has said, please speak for me if I can't speak for myself, listening. Because that was my job prior to that point when they couldn't speak for themselves. That was my job, to listen. So the thing that in coming into that, I also got training as an advanced care planner, meaning I help people with the documents, and also got training as an end-of-life doula. Some of you may be familiar with the word doula, birth doulas. I had support at the time of the birth of my child. Before the birth, at the birth, after the birth. And at some point, somebody said, we've got support, non-clinical, support for folks at birth. How about support for folks at death? So the concept was having non-clinical folks in a variety of support. So I have training in that. So I so appreciate following Dr. Vaughn today because she alluded to so many things, but my intention today is to not only provide you with your action plan, but to provide you with some tools so that when you leave here, you've got some things in hand. So one of the things that Dr. Vaughn talked about, and I want to reiterate, are the legal choices of what everybody has a right to do. And this doesn't apply just to those with a particular diagnosis and those of you in this room. It applies to everybody. Everybody has choices. Everybody has a right to make their decisions, and everybody has a responsibility of telling somebody else about what it is that they want to have done, and not only tell them, but write it down. So that combination. So you have a right individually to continue in your care, continue in your clinical trials, continue in your testing, continue potentially in surgery. You have a right at some point to stop treatment. You have a right to hasten your death. You have a condition, it is progressing, and at some point you have a right to say, wait, I'm going to let it continue naturally. It's going to end when it's going to end, or I'm going to stop and it's going to end when it's going to end, or I potentially have a right to hasten. Dr. Vaughn talked about the law that makes it legal to use medical aid in dying, but what happens if you don't qualify? She indicated the eligibility, have to be 18, have to be a resident of the state, have to have a terminal condition, most importantly, decisional capacity and ability to self-administer. talk a little bit about, and not from a clinical perspective, because I need the clinicians in terms of the clinical perspective on this, but decisional capacity is quote unquote easier in this arena, because it doesn't matter if you don't know what day it is. And it doesn't matter if you don't know where you are. It matters if you know your diagnosis, you know the physical condition that you have that makes you eligible. It matters that nobody has talked you into this, that this is your own decision. And it matters that you verbally can indicate what's going to happen when you take the medication. So you have to know how you came to this. You have to know that you're making this decision on your own. And you have to know that when you ingest or administer the medication, what the result is going to be. You have to be able to indicate that you know the result is going to be your death. That's decisional capacity. The self-administration, quite honestly, is thumb dexterity, because you can ingest orally or rectally, but you have to be able to have an ability to connect the plunger, or through a G-tube. A G-tube cannot be inserted to do this. So if you are on a G-tube, then thumb dexterity. So it's all of those things. So going back, what happens if you're not eligible? You don't meet the decisional capacity. You can't self-administer. The other option is VSED. What's VSED? Voluntarily stopping eating and drinking. Now, in a natural process of dying, we're going to lose a desire for food. We're going to lose a need for hydration. That happens naturally, but in VSED, voluntarily stopping eating and drinking, you are making the decision to stop. Not in the natural process, you're making a decision. It is not an easy decision, and it requires support. It's not an easy decision, it requires support, and we come around to the importance of the relationship with your palliative team, your hospice team, to be there for that process. But it's one of the things that says you want to have choices about what it is that you're doing, and it may be that you're not eligible for medical aid in dying, but you are eligible under VSED, voluntarily stopping in the eating and drinking. All of this, in this process, it's always weighing quantity over quality. Quantity is how long is your life going to be. Quality is what is, literally, what is my definition of my quality of life? And we define it lines in the sand. I hit this line in the sand. Quality is not what it is that I'm looking for. Therefore, this is what I want assistance, either where I'm verbally giving it or I can't do that anymore, and my agent is doing what it is that I've asked. This is my line in the sand. It changes. And that's why it's important in knowing in your advanced care planning how important it is that you can change your mind. And again, Dr. Vaughn said this, you don't have to have an attorney involved in this part of your planning. Rip, rip, rip. You can tear it apart. You can change your mind. The piece that's important, again, you can change your mind about the person that you name to serve as your agent, as your person speaking for you. Not a difficult process to do that. Doesn't require an attorney. Rip, rip, rip. You do the next document. Rip, rip, rip. What are we ripping up? It's the pieces of paper. Let me show you the first present I have for you today. So first one, Compassion and Choices it's a wonderful national advocacy group advocating for passage of law. They provide wonderful, wonderful material. So I brought for everybody today, I've got plenty of them. So if you've got a friend at home, you can take one. This is a wonderful conversation starter because throughout this, if this, then this. if this, then this, and you have an indication in doing your values, what's important to you, and letting it be known. So you complete the document, you sign it, you put it in with your paperwork. It has a dementia addendum in it, specifically on a change in cognitive ability. What do I want if I'm not recognizing people? What do I want if? So there is a specific dementia addendum in here. The other thing that I put in here, three other things, information about End of Life Options Colorado, how to go into our website, a little handout, how to have conversations with your doctors, how you choose, not just your doctors, your clinicians. It may be a physician assistant, it may be a nurse practitioner, how you have conversations about what's important. And then thirdly, there is a sheet of links to resources. I highlighted End of Life Options, also other resources, and below document links, so that in this piece, these are your instructions. Separate document to name your person. So our links in here to just pull off the medical power of attorney, Colorado medical power of attorney that you can complete. So those are presents for everybody that I brought today. Because what's important is not only that you've given what it is that's important, you've talked about it with as many people as you want to, you've written down what it is that you want to have happen, and you've had more than one conversation with the person that you've named as your agent. I mentioned that I've served professionally as a financial power of attorney, a medical power of attorney. And I hate to tell you how many times I've gotten a call at 3 o'clock in the morning from the hospital that somehow has tracked me down and said, I understand you're Mary's medical power of attorney. She's here at the hospital. Can you come over? I've never heard of Mary. I was named on her documents, but I wasn't contacted by the attorney and I wasn't contacted by the person. I have no idea who Mary is. And I'm going over at a time to make decisions for her of what it is that she wants. And I, in a Sherlock Holmes way, the best of my ability, try to figure out what she might want. So the thing that becomes important when you're doing this, have conversations with the people that you've named and make sure you've chosen the right person. It's not always your spouse. Your spouse is not always able to make very difficult decisions at a highly emotional time. So sometimes it's not your spouse. The other day, I heard a woman talking about her documents, and she said, not only in my documents have I named who I want to speak on my behalf, I've specifically named who I don't want. She has 3 children. She said, my 2 sons know exactly what it is that I want, and they will do it. My daughter will keep me alive forever. I have told her she is specifically not named in my document and specifically doesn't get a vote. And the daughter knows this, and she's kind of relieved the daughter of the responsibility. So she did both, and she did the other thing. She got them all together. They had a conversation, and the daughter's okay. The daughter is relieved that knowing that she will want to do what she wants to do, but she's relieved that the mother has taken care of that. So my conclusion, and then Dr. Vaughn and I will open this up to conversations. Think about your values, think about what's important to you and the decisions that you want to make. Write them down, have a document that names the person that you want to speak for you if you can't speak for yourself. Have another conversation with that person to make sure you've chosen the right person. Complete the dementia addendum and have that in your documents. So a shift in your cognitive ability, that you've got that documented. And then be aware of the 2 things that I didn't talk about today, but that in your just thinking about as we're planting seeds about the things to talk about, Think about at the time of your death what you want to do with your body disposition, and think about what do you want to do with your stuff. So in your thought process, if you're having conversations with an end-of-life doula, you're having your conversations with your care partners, you've got that time from now up until your death, you've got the day of your death, and you've got what happens after your death. And regardless of a medical condition, that you now have a known condition that might have a terminal end for you, where you can name it. This applies to everybody. This applies to me. It applies to everybody in this room. Everybody needs to have the documents, have the conversations, and live their life in between. So taking charge of and taking care of business, because that's what I'm talking about here. This is the business. This is taking responsibility and then put it someplace where everybody knows where you've put it and live your life to the very best. So Dr. Vaughn, why don't you come on up here and we can be available for questions and what, from a non-clinical perspective, I gave you your to-do list, provided you with some tools to complete, and then we can go forth here.